we've talked so much about ovarian cancer, and I really want the viewers to be aware that some of the new science is really demonstrating that the majority of these cancers probably come from the fallopian tube, that there's a precursor lesion, which means the non-cancerous lesion that develops in this tube that ultimately becomes a cancer. And what happens is these cells travel, deposit on the ovary, and the ovary is like the poor innocent bystander. So specifically for some of these cell types, like the high-grade serous cancer type, we think that most of those are actually coming from the tube, depositing on the ovary or the peritoneum. So now we recognize that the ovarian cancer, the tubal cancers, and these peritoneal cancers, they all are probably the same kind of underlying process, and they're trying to come up with a good name. One of the names that's been given is adenocarcinomas of Mullerian origin, but it's just hard to say that, right? So I think by the default,
we'll definitely come back to talking a little bit more about the biology of these tumours. Now, you've already talked about non-specific symptoms, and you've touched on how some patients may present with a mass, but we know in the female pelvis there's a lot going on in a small space.
Yes,
with
there is.
The bladder and the reproductive organs, the uterus, the ovary, the fallopian tubes, the bowel all around that, and patients are getting bigger and larger. We're seeing patients who may not necessarily be able to detect a mass if they may be overweight. How common is it to present with a mass, and is that the commonest way that your patients present with ovarian cancer?
So again, fantastic point, because we've seen this huge shift in the obesity epidemic in the United States, where at one point you could do a pelvic exam and actually palpate the female reproductive organs to a time in this era where you could do an exam and not really be able to feel anything.
So what you're saying is that some women may have been detected as having a mass at, say, their routine annual gynecologic exam?
I think some, but again, I want to make sure that I don't create any misunderstanding. Even in that era where women were smaller, people were smaller, the majority of women were not detected on exam. And that's because, as you mentioned, there's so much going on in the pelvis. There's a lot of room to hide a mass in the pelvis that you could miss on exam. So even in that time period, 20 plus years ago, the majority of women were still diagnosed with advanced stage disease. The clue is really those symptoms. And I know Michelle had some of those symptoms, right? So for women to be aware of those symptoms, such as abdominal pain, bloating, fullness, feeling full earlier when you eat, a change in bowel movements, and you mentioned incontinence, so urinary frequencies, a big one, absolutely.
And I mean, let's be real here. How many of us don't go through an average month without a sensation of bloating or abdominal discomfort, these non-specific symptoms? How do we communicate to our audience that you don't need to go running off to the doctor every time you feel a bit full, a bit distended, a bit gassy, a bit constipated? How do we figure out patients that have symptoms that we really are concerned about?
So I'm so happy you raised that issue. If it is occurring daily for 2 to 3 weeks, that's something that's not normal. We all have those symptoms every once in a while. I don't know, maybe you don't, Greg.
Yeah.
But,
he has the sympathy ones.
I think a lot of women do experience those symptoms, maybe a day or 2 in a row, but it's not something that's constant every day for 2 to 3 weeks. If you're having those symptoms, contact your doctor.
No, and we do hear so many times on these segments that we've covered with Cure Connections, where the patient, they know something's not right with their body. They go to the doctor, they tell them about these non-specific symptoms. They're looking for medical advice to take some tests further down the line, or maybe to give them reassurance. But so often patients have said to me in my own practice, and also we've heard this time and time again on Cure Connections, I went to my doctor, I knew something wasn't wrong, but my doctor just kept telling me it's nothing to worry about. I was reassured, and they weren't taking it down to the next step. How do we encourage the medical profession to sit up and listen when the patient is delivering us the warning symptoms, but we're not hearing it?
Yeah, so that is such a key point. Education is very important, but it's also understanding that those symptoms could be something more. this can be a really hard clinical decision. I mean, that's the art of medicine, right? When is it irritable bowel syndrome versus something more ominous? When should you get a CT scan versus a pelvic exam or an ultrasound? And that can be very difficult. I'm on the easy side of this. Someone comes to me, they already have a diagnosis.
Sure.
The care providers that are the front line, the general practitioners, the nurse practitioners, the PAs, and so forth, I mean, their job is probably much harder than mine in terms of identifying who needs additional study. So I would say this, if you have a patient who comes and has those complaints, and they've been occurring for 2 to 3 weeks, and you think it's IBS, it may be appropriate to try them on a trial therapy for IBS. But if they don't improve within the next 2 weeks, I would get a scan.
Sure.
And also be aware that your scan can still be negative and they're having symptoms. And that might be time to refer them to a gynecologist or to a gynecologic oncologist. I have had patients who have had a negative CT scan, who've had a negative ultrasound. On pelvic exam, I feel something. I go to the OR to do a diagnostic laparoscopy, and they have cancer.
Right.
So I've seen that more than a few times.
I'm sure you have. I'm sure you have.